should be good to go in a moment. Hi, everyone. Thank you for joining us today for the panel hosted by Venture Partners and Patientory. The topic is the AI health data KPIs that matter to payers and health system. This is Pankaj Gupta from Venture Partners. We are a deep tech revenue scaler and fund based in Singapore with approximately 120 startups from different parts of the world, stages, and sectors. In the US healthcare landscape, payers and health systems are sitting on oceans of claims, clinical, social determinants, and now patient-generated data. And because of that data on which we are sitting, AI is no longer a nice to have. It is the new engine that turns that data into measurable value. But obviously, not all KPIs are created equal. Today, we are cutting through the hype to focus on the metrics that actually move the needle for the payers and improve population health. And to provide the real insights on this topic, we are joined by 5 distinguished leaders who are dealing with these challenges and innovations on everyday basis. Before diving into the panel discussion and some really interesting insights and questions, I would request our panelists to introduce themselves. I see Başak on my screen. So Başak, may I request you to quickly introduce yourself, please?
Sure. Thank you for having me. I'm Başak Altan, a design strategist focusing on AI in healthcare. My work centers on how systems come together around people and how we turn complex data into decisions so that clinicians and operators and members can actually act on. And I spend a lot of my time looking at where AI works in theory versus where it actually works in practice, especially how it shows up in workflows, how it builds trust, and how it ultimately drives real outcomes at scale. Wonderful to meet you all. Thank you for this opportunity and the conversation.
Thanks a lot, Başak. Really appreciate your time today, and we are really looking forward to your insights. Appreciate that. Navneet, may I request you to go next, please?
Great, thank you. And thank you to the organizer for the invitation, and look forward to the dialogue. I'm a clinician, an internist, and been in academic organizations for the majority of my life, except recently moved over to the more entrepreneurial side. And now I focus on supporting health systems, health insurance companies, and startups on utilizing data, but with the focus on ensuring that clinicians, especially primary care physicians, can be supported from the vantage point of addressing burnout and getting through their workday. So I look forward to the engagement. Thank you.
Fantastic. Thanks a lot, Navneet. I think you have done a lot of really interesting things throughout your career. So your insights are also going to be extremely fantastic. So thanks a lot for joining us today. David, may I request you to go next, please?
Yeah. Good day, everyone. I'm so glad to be here. And I'm David Dobbs. I'm recently retired as the Chief Data Officer from a Blue Cross Blue Shield health plan. And I led the data strategy and made the organization's data AI ready at that organization. I also have experience in the provider setting. I served as the Executive Director of Data and Analytics at the University of California, San Francisco, where I designed and launched the Enterprise Data and Analytics Department to support patient care research and education. I also have a lot of experience in healthcare data interoperability and served on the U.S. National Health Information Technology Standards Panel to advance bidirectional sharing of clinical data with public health and providers, and just have a real love for data and how it can be used to drive business and health improvement.
Fantastic. Thanks a lot, David. It seems that you have dealt with data quite a lot. And obviously, AI is picking up now, but you have been dealing with data for decades, for the last few decades. So really, really appreciate your time today. Chrissa, may I request you to go next, please?
Yes, thanks again, Pankaj. Really excited to, be amongst everyone. I'm Chrissa McFarlane, the founder and CEO of Patientory. We are a global health data infrastructure platform that aggregates health information and provides a personalized health data wallet for individuals to manage and control their data, but also prevent chronic diseases at scale. We've received notable investments from organizations like Kaiser Permanente, Blue Cross Blue Shield. We recently expanded into the Asia market, specifically in South Korea. Prior to this, I, pretty much helped develop a telemed company that later exited. And I currently sit on the board of Care Equality, which is the government adjacent organization that is required for pretty much advising on patient access to data. We're also part of the CMS health tech ecosystem in the US.
Fantastic. Thanks a lot, Chrissa. It's also very important to have the insights from the entrepreneurial side of the world. So thanks a lot for joining us today. May I request Manash to go next, please, Manash?
Thanks, Pankaj. Excited to be part of this illustrious panel. So my background is a little bit different. I come in from a financial and consumer industry. I've been in the healthcare industry for the last 3 years, and wow, it's been such a refreshing area. So I work as a general manager and SVP of product at HealthEquity. At HealthEquity, we are sitting between financial data, healthcare data, and consumer data. And what we are trying to do is create HSA and FSA as a benefit platforms that helps our consumers, our clients manage their healthcare needs, as well as save for the future. So it's been very exciting to see the amount of investments which is going into the healthcare, which is now I think close to 4 trillion, and still the gaps that exist from consumer experience from a data perspective. I don't think anyone would have gone for an X-ray and said, "Oh wow, I had such a fantastic experience. I could see the cost of the X-ray upfront." It's simple thing like X-ray, right? Like I could understand what's the quality, who is going to do that, how much is it going to cost me upfront, how much is it going to cost me later. Just an example of the anomaly that we see in this industry. So looking forward to the conversation.
Thank you. Thanks a lot, Manash. And as you said, you come from different industries, and now you are probably implementing the learning of other industries in the healthcare space as well. So that's really fantastic. We are really looking forward to your insights today. Again, thanks a lot, all the panelists, for joining us today. We will have 5 different themes, 5 different questions on which we will get your insights. We'll first talk about AI-driven health data KPIs. What are the main KPIs that really matter? Then we will get into data readiness and quality. After that, we will be talking about operational and financial impact of these AI solutions and obviously these KPIs as well that we are measuring. Then we will move into the population health and outcome. And after that, we will talk about the ROI, the scalability, and future outlook of these solutions of the AI systems, and so on and so forth. So starting with the first question, I would request Navneet to share his opinion on top 3 AI-driven health data KPI that your organization is prioritizing right now for population health and cost management. And I think the bigger question is, why do these KPIs matter more than the others in 2026?
Right. So I'm going to focus my comments on some recent work here in New York City. And, very competitive market, right? So patient access is a critical area of focus, right? Both in terms of new patients coming into the system for primary care, urgent care needs, as well as, especially with the large academic centers, access to specialists, right? Because as we all know, that it is the specialists that often drive high value revenue streams for health systems, right? So ensuring that patient access is timely, aligning the right patient with the right clinician, right? Especially when it comes for specialists, are indeed quite critical. Right, so we're looking at on a regular basis, how long does it take to get an appointment for a new primary care visit how long does it take to get an appointment with a specialist? And then from the specialist vantage point, right? So I trained as a hematologist. I know I would get lots of consults that I could have just as well easily answered if I had the patient's chart. So we're looking at how do you institute and roll out, right, e-consultation for specialists to address that timeliness of access for specialty care, right? And all the data is indeed there. So for me as a hematologist, if someone is referred to me for evaluation of anemia, and if we have their chart, we have their laboratory data, I could relatively quickly discern what are the next steps that need to be done for that patient before he or she comes to see me for an actual visit, and I can communicate that to the primary care doc to ensure that. So timeliness of patient access for primary care and specialty physicians is quite critical. And then the last element that we're focused on is, with the introduction of AI, what is happening with regards to indicators of primary care burnout? And that is a key challenge because there's a severe shortage of primary care clinicians, not just here in New York City, but around the country. So those are the other key measures that we're constantly looking at and focused on going into 2026 as well.
Fantastic. Thanks a lot, Navneet. Let me bring Chrissa to respond to this question. Chrissa, are you available?
Yeah, sorry about that. It seems I was frozen for a bit. But yeah, just to go ahead, and add on to that from our perspective, especially at Patientory, the top 3 AI-driven health data KPIs we're prioritizing for population health and cost management. The first one being engagement to adherence conversion rate. In our pretty much discussions with payers, this measures how effectively member engagements such as app usage, coaching interactions, wearable data translate into real behavior change. So medication adherence, activity, and care plan compliance are all, part of this. Especially now, in 2026, this matters because engagement alone doesn't drive outcomes, as we know, but behavior change does. And this KPI directly ties digital interactions to cost reduction and clinical improvements, which has been pretty much, top priority for payers. I would say the second one is real-time risk detection and intervention latency. So with our company, we track how quickly we can identify, rise in risk members based on longitudinal data signals and intervene, right? So this KPI is measured as time from signal detection to actual intervention. It's critical because reducing latency directly impacts avoidable ER visits, readmissions, and disease progression, right, which are the largest cost drivers currently for payers. And I would say last but not least is, what everyone has been trying to solve for the past decade or so is the longitudinal data completeness per member, right? This measures the percentage of members with continuous multi-source data, which may include, claims, clinical data. Now we're seeing a lot of wearable device data, as well as behavioral data that we can capture, from the user on a daily basis. So AI, models are only as effective as the data they ingest. So, we want clean data in, clean data out. And the differentiator is not more data, but more connected, continuous data, across the care journey, enabling better predictions, personalizations, and then we can actually get to ROI at scale. So I would say, these KPIs matter more than the traditional metrics because they directly connect data, which leads to action, which leads to outcome, and we can then exactly like quantify costs, which has been pretty much more qualified than quantified. And I think that's where payers need to justify, that AI investment and succeed in, that value-based care environment.
Fantastic. Thanks a lot, Chrissa. So if I understood this correctly, time to connect with the doctor, time to have the intervention, behavioral changes in the patients, the medical adherence, these are some of the most important things that you are looking for today. Thanks a lot. And because you talked about the data, the quality of the data, the readiness of the data, I'll have to bring in Başak and get her feedback on, on the data readiness. So many peers do struggle with AI-ready data, drawing from frameworks like data completeness, timeliness, accuracy, and governance. Which data quality KPI have you found delivering the biggest lift when feeding AI models? And how do you actually measure and improve these KPIs? Başak, please.
Yeah, so I would want to step back just a few seconds. I think as payers, we really have to decide what business we're in to answer that.
Right.
And are we in the business of selling products, or are we in the business of serving people? If we see ourselves primarily a product organization, then AI gets applied toward our optimization, efficiency, and cost, and those things matter. But if we recognize that we're fundamentally in the service of people, especially at some of the most vulnerable moments in their lives, then AI becomes something different. It becomes a way to reduce friction, build trust, and also help people navigate complexity across systems. And that distinction really shapes what we measure and prioritize and test, right? So and measure. So because we're in the service of business, then KPIs like trust, engagement, clarity of decision making, and aren't secondary KPIs, they're primary. And that's also where human-centered design and even more agentic AI approaches start to matter, and because they're focused on supporting people in context, not just optimizing systems in isolation. So specifically to answer your question about KPIs, what I've seen is that traditional data quality KPIs still matter a great deal, especially in terms of completeness and timeliness. But what creates lift in practice is whether that data is connected and it's also contextualized and available at specific moment when someone needs to act on it. So in many organizations, the real issue is really not lack of data. We're getting better at clarity of data. It is actually fragmentation. So claims, clinical, operational, and member experience signals often really sit in different systems, and they're usually owned by different teams. So people spend so much time assembling the picture and not enough time making decisions. And that is why I really think we need to move beyond the idea of AI-rated data, which we are deciphering currently, more towards the decision-ready data. So the biggest lift comes when data quality is really paired with orchestration. And that means reducing the time it takes to move from signal to actually action. So making sure that information shows up inside of a workflow and not just in a reporting format, in a reporting environment. I can give an example of this. A powerful example is reducing the time it takes to assemble a member record, for example. When data is centralized and identity resolution is stronger, clinicians or care managers or operations teams can spend really less time hunting for the context and more time intervening on the issue. So that might sound really operational, but that is exactly where AI and the measurements are more effective. So that I would say organizations do not just need better data pipelines. We need better decision pipelines, and those connect to how we see ourselves, what role we play in. And I think internally in a lot of the organizations I've heard, cost, efficiency, it's important.
Right.
But it's also important to define clearly what lane you're swimming in. Because if you see yourself beyond that, serving people in the business of service, then trust needs to be measured, not just a soft element. And I think we need to spend more time there. as a KPI measurement if we
Fantastic.
see ourselves in the service side of things.
Thanks a lot, Başak. And let me ask David his insights, because David, you dealt with data for decades, right? So what are some data quality KPIs that really matter to you the most?
Great. Thanks, Bhattacharjee. And let me step back a little bit before I go into the specific KPIs. I think health organizations, by and large, are in the state of trying to just collect as much data as they can, hoping to make it useful at a later date. And within my teams, I've coined the phrase the data value chain. And the data value chain is really that set of practical value accreting steps on data that refines the data into that actionable intelligence that drives improved patient and business outcomes. That data value chain set of steps that as an organization need to be agreed upon, and whose responsibilities are. What's the business's responsibility? What's the finance team's responsibility? What's the technology team's responsibility in that data value chain? That has to kind of be agreed upon. And the way my teams have done it is that the data quality is a work stream in that data value chain. And for data quality, the last I checked, there is no universally accepted data quality metrics in broad use. So, my teams and I have focused on a set of 4 data quality characteristics that allowed us to very practically improve the quality of data and make it AI ready. And these characteristics spell out the acronym TACT, T-A-C-T. The T is trustworthiness. And by that we mean, is the data fully documented in the data catalog? And does it have oversight by business data owners and technical data stewards? And really, is there some clear and clean lineage back to the governed systems of record or sources of truth? So is the data trustworthy? The A is accuracy. It measures the degree to which enterprise data agree with the definitive systems, such as the system of record, right? And if you don't have accurate data, then you're going to have bad results from analyzing that data. The third is unique complete data, and this measures whether or not the data has the complete set of records. Do you have all the records of laboratory tests for an individual, let's say, and on those laboratory tests, do you have all the data fields filled out that are important to drive the decisioning off that data? And so, we have trustworthy, accuracy, completeness. And then the final measurement of data quality that we focus on is the timeliness of it. And that measures the latency of the data in the enterprise data store compared to that in the system of record. And so with AI, what we found is that since a lot of these predictions that it makes are real time and need to be up to date and informed by up to date information, that the timeliness of the data is one of the most important data quality characteristics. And so we've really kind of pushed to try to make our data platform have real-time data or near real-time data, and a lot of the interoperability, healthcare interoperability requirements that CMS is pushing really kind of push us towards the FHIR standard, FHIR standard from HL7 for real-time data sharing between EHR systems and with health plans.
Fantastic. I think, David, the way you have simplified the data quality characteristics by sharing TACT, I think this is fantastic. This is amazing. Chrissa, what do you think? What are the KPIs, data quality KPIs that matter the most to you?
Yeah, and I was, listening to both David and Başak, and it's interesting because none of them said, which is a good signal, that we need more data. And I think the key insight there is that AI readiness isn't just about more data, but it's about connected, timely, and behaviorally rich data that reflects what's actually happened, right, with a member from day to day. I know David brought up, one of the bigger points, which is interoperability. That is now at the forefront, right? Because with interoperability, we can ensure completeness, right? We're not making decisions on partial records. We can also ensure timeliness, which is critical for intervention, right? Claims data that's 30 to 90 days delayed versus near real-time device or engagement data changes outcomes significantly, right? And our measurements significantly, as to how, payers are able to save costs and, members are actually, adhering and complying to those care plans and behavior changes. I think from a measurement standpoint, we operationalize this through KPIs like percentage of members with multi-source data coverage. Going back to interoperability again, centralized data was either from the EMR or, from, different systems. I think we're at a point in time now where we can see that amalgamation of different types of data sources, right? Especially, what we do at Patientory is, really using decentralized infrastructure, right, to secure information so that we can collect it from multiple sources. So whether that's the electronic medical record or, a wearable device or from a lab, right? We can start to incorporate more of that day-to-day information, which can, ultimately, create that completeness and better AI generation.
Fantastic. Thanks a lot, Chrissa. So,
Pankaj, I
sorry,
just want to
please,
add
Navneet.
one word. Great comments by everyone and really quite helpful. So from the vantage point of a clinician, I started practicing medicine and I was still writing notes and charts and stuff. So what I think about data is data helps me as a clinician to deal with the uncertainty. The uncertainties of seeing a patient and not knowing all that they've had done, right? Whether it's regards to primary care prevention, whether it's regards to making a decision about which antibiotic. So information helps me to deal with the uncertainty that I have when a patient is in front of me, and that information and data decreases that uncertainty gap, right? And that I think two of the panelists mentioned trust, right? So for me, it is trust in that data that minimizes that uncertainty of the action that I'm going to take. Because I'm constantly dealing with uncertainties. Have I made this right decision? And whether it's ordering a colonoscopy, yes, I made the right decision because there's no record of it, right? So I trust it and it minimizes that uncertainty. So I just thought that's something that's just kind of struck out at me when folks were talking about trust. Well, for me, it was from the vantage point of minimizing the uncertainty of the decisions that I'm making when a patient sits in front of me.
Interesting.
Can I also add something from the consumer angle?
Please, Manash.
Yeah. Predominantly, we have been talking about provider side, platform side, hospital network, etc. What do consumer care for, right? So I, as a consumer, I care for things like, hey, what would it cost me? So, for example, I have a particular issue, right? What would it cost me if I have to go through a particular provider versus another provider? Is this issue solvable through medication or do we need surgery? How can I trust the advice which is being given? How much did someone else had that experience? What do I learn from their feedback, right? So those are all the different pieces that a consumer are interested in. Just a small set, right? The challenge which we are seeing is all the different platforms are siloed data. Like the hospital network has siloed data, your wearables are siloed data, your insurance provider is kind of siloed data. Like how do we break or create a a trusted ecosystems that can get data from all these different separate modes and bring it together to create a personalized view. I think that's the real goal for all the effort which is also being done around AI and simplifying the consumer experience.
Fantastic. Thanks a lot, Manash, and I'll be taking your feedback on operational and financial impact that these operational KPIs may be driving. But if I have a bit of flexibility over here, probably I would like to change TACT with ITACT: interoperable, trust, accuracy, completeness, and timeliness. If you allow, David, apologies for taking that liberty, but I think that makes complete sense. But yeah, Manash, so there are a lot of operational and financial impact that the payers are expecting. They are seeing through these operational KPIs, and it could be anywhere from claim auto adjudication rates and denial reduction to medical loss ratio improvement and fraud abuse detection. Which payer-specific operational KPI do you think have seen AI move the most dramatically? And probably you may want to share some quick win or some cautionary tale or anything of that sort.
Yeah, no, I think I can share some of the perspective that we have. So one of the things which is rising consistently is the cost of benefits that organizations are providing to their employees, right? So if you look at Boeing, Lockheed Martin, Google, Facebook, all of them provide really good health insurance support.
Yes.
Now, what's happening in the last 7 to 8 years is that the cost of health insurance is increasing. And one of the factors driving that increase is that the cost of healthcare is increasing. Now, the other factor is also important is that if the employees are being intentional of leading a healthy life, if the employers are able to drive their employees to lead a healthier life, that cost to the employer overall decreases, both from a direct cost perspective, which is healthcare cost, and indirect cost perspective, which is like improved productivity, and other factors.
Yeah.
So one of the areas one of the KPIs that we are highly focused is like, what is it costing to our employees or our employers or clients, right? How are we creating platforms, ecosystems, experiences which is helping them reduce the cost of the healthcare, right, for their healthcare benefit to the employees. I think that's one. The other operational KPIs or like financial KPIs that we look at is, after retirement, how much does it cost for an individual to have to support their medical costs, right? So the numbers are rising. Right now, I think it's around 200K to 300K. So after you retire, right, from your work experience, and even if Medicaid is there, Medicare is there, you still have to shell out around 200K, 300K individual in US in order to support your medical needs, right? And with longevity increasing, that cost is also going through a increasing. Typically, the 401K savings that a lot of users have in US, it's not enough, right? So that's where the health saving accounts comes into pictures and becomes a big area of focus. So the financial capabilities and other operational KPIs, which is at the individual level, that we focus. The third KPIs that we focus is emergency readiness, right? Like, are you able to support a emergency healthcare bill? Are you able to support a emergency healthcare situations like broken fractures? Majority of the US consumers are not able to support a $500 emergency bill, right? So what percentage of our consumers or members are able to get to that level of support? That's another financial KPIs that we look at. So that's just a nutshell from outside of the payer provider ecosystems. Like when you're looking at it from consumers and client and employers ecosystems, what the lens looks like.
Interesting. Başak, what is your opinion on that? What are the operational or financial KPIs that you're looking at?
Yeah, so in one of the biggest operational gains I've seen do not come really from having a model, like having an advanced model. They come from how do we embed the AI in places where work is actually already happening. So that is where it starts to move operational KPIs in a meaningful way. And specifically in payer environments, some of the clearest opportunities are in the care manager workload prioritization. So case preparation, call center operations, and other high volume administrative workflows, because in these areas, AI can improve throughput and reduce that manual triage, and also shorten some of the cycle times and help people focus attention where it actually matters most. But there is also a cautionary side to this. If AI is not really integrated carefully, you do not eliminate the bottleneck, you just simply move it. So you may speed up one part of the process while creating confusion, rework, or escalation somewhere else. So that is why human in the loop design matters so much. The question is not just whether AI can produce an output, but whether people know how to trust it, interpret it, and also act on it, right? So one example is the care manager workload prioritization. AI helps surface some of those members that need attention now, instead of really relying on the first come, first serve approaches. So it can improve cases reviewed per care manager. It can reduce that time to intervention, and it can also lower that triage effort. But that is a quiet but meaningful win, because it improves throughput without increasing staff needs. You know, a theme that's coming through in the industry is that this workflow integration is the new battleground. The question is less about what can these models do, to more about whether it can really change the work on the ground. That's where my mind is at this week.
I think the other element that is critical is you know, just the term artificial intelligence. You know, for those that are not steeped in it, who don't understand all that artificial intelligence is and whether machine learning, I think there's an element of education and learning that needs to happen within the organization itself, right? And I think, you know, what you were talking about, Başak, is from my vantage point, a project where I worked on was, you know, using robotic process automation. We did not introduce any, you know, nth generation ChatGPT models. They were just looking at their processes, which were codified on paper, and automating them.
Yeah.
Right. And when we initially introduced it, we said, oh, this is the artificial intelligence committee. Everyone's like, oh my God, there's going to be hallucinations. We said, no. We said robotic process automation. Boom. It was so much easier. So I think there's an element of education that needs to be done as well. You know, there's artificial intelligence, there's artificial reasoning. So I think those of us that are engaged in it, first and foremost, make sure that we, you know, get everyone on that same playing field, and we don't kind of, you know, confuse them about what is it that we're trying to do.
Right.
Exactly. Yeah, I totally agree with the whole explainability side of things, because that becomes critical, not just compliance. That is another human element here. Are we aligned on what we're describing? And there is a lot of noise. There's a lot of AI theater. So we need to kind of be able to come to the minimum understanding of what everyone is talking about, so that we can follow along. Otherwise, everyone's saying different things and meaning different things. And that's where confusion starts to unfold.
And I'm wondering if anybody has seen any big significant impact on fraud, abuse detection because of the AI solutions that you are integrating into the payer ecosystem.
So I work with the largest workers' comp insurance company in New York State. And as you know, common, use, abuse, overuse of narcotics is a huge, huge challenge.
Right.
When you process close to about 150,000 claims on injuries, and what we were able to do is we were able to utilize, I wouldn't say artificial intelligence, but just simple machine learning processes to identify, certain anomalies in the prescription patterns in various regions of the state, in New York State. And that allowed us to, identify things that just look strange. And then we had our case managers go in and review the cases, and lo and behold, there were things that were happening that should not have been happening.
Right.
And again, it wasn't, again, as I said, artificial intelligence. It was just pure and simple, basic machine learning, statistical analysis of large volumes of data and prescription patterns.
Yeah.
Interesting. Sounds fantastic. And now I think it's time to move to the next question around population health and outcome. And I would request Navneet to share his insights on, AI is powering predictive risk scoring, chronic condition management, and value-based care programs. What population health KPIs are payers now holding AI initiatives accountable to, and how do you close the loop from insights to intervention? Navneet, please.
Yeah, and so again, for me, it's the interface between the clinical teams and the payers and the administrative team, right? So my first, recommendation or suggestion when I ever go into these conversations, don't start off by saying that we're going to focus on population health, which kind of says, you physicians weren't focusing on population health, right? So we as clinicians were focused on patients with diabetes. That was our patient population. We were focused on patients with congestive heart failure. That was our patient population, right? The Affordable Care Act, for the last 10 to 15 years, population health management, right, with all due respect, is focused on cost management, right? And so you go in with the notion that, yes, we're going to focus on population health. There's that clinical element that we focus on population health with regards to all of your congestive heart failure patients, on ACE inhibitors, or all of your diabetics having their glycosylated hemoglobin measured on a regular basis, right? So those are indeed the clinical elements that we always need to adhere to, because, the largest group in population health is Medicare, right? With over 11 million patients in their ACO, value-based care arrangements, right? So the clinical elements are always there. And every year you align those clinical metrics with what Medicare is asking you to focus on. 10 years ago, post-MI, everyone should be on aspirin. We don't think about that anymore because we've reached a point where more than 80 to 90% are on, aspirin. So now we focus on other things. So first and foremost, the clinical elements, because that's the easiest way for us to engage with the physicians, right? And then you get to some of those more challenging things which impact cost, right? Whether it's the readmission rates, whether it's the overutilization of emergency departments, whether it's long stays in SNFs, whether it's a rapid rise in the use of biologics, whether it's in the use of MRIs for low back pain, which is, again, distinguishing high-value care and ensuring that low-value care is also being focused on. So those metrics come into place dependent upon the given contract that you have. So the most recent one, we're focused on SNF utilization, and SNF utilization not from the vantage point of length of stay, but ensuring that the SNF utilization is happening within our networks or within the networks of the payer and the providers, right? High-cost biologics, a huge challenge, right? Patients go see clinicians, they go see physicians, and they get started on biologics, and boom, the costs start going through the roof. And then the last one that we're focused on is radiology, right? High-cost radiology is indeed a big challenge. And those are the specific KPIs that for this year, that this group that I'm working on is highly focused on. And again, the clinical metrics, the HEDIS metrics, they're always there. That's just the baseline, right? That it's like, you have to constantly work on that.
Yeah. So population health has always been the focus. Now there are new elements that are emerging and that could solve the cost efficiency quite significantly. Thanks a lot, Navneet. Manash, from your perspective, what are those outcomes or KPIs that you're driving for? You're mute.
Sorry, we shared some of the KPIs which are like from the client perspective, employer perspective, consumer perspective, etc. The other KPIs that we are very focused around is digital adoption, like how many of our consumers that are using our platforms, what channels they're using, right? So one of the key KPIs that we are looking is mobile adoption, like how many people have downloaded the mobile, how many people are using the mobile, what's the frequency of use, which areas are they using, what features are they using. So we are bringing in that consumer and fintech landscape into the healthcare ecosystems by looking at digital adoption as a way of like a measure of utilizations and self-service. The other KPIs that we also look at is predominantly what's the lifetime value of our members, right? How are we helping our members get more benefit from the systems, but we as organizations are also driving more benefits. In our industry, because we are overlapping financial industry and healthcare industry, one of the key KPIs is also how much assets we have. Like in that sense, we work a little bit like a fintech industry, and we say, okay, how much assets we are managing, and we are in the $36 billion asset space. So hence, it's a big KPI for us in order to track the benefit we are providing and also the trust that consumers have on us.
Fantastic. So these are very different KPIs. What we heard from Navneet and what we are hearing from Manash are very different KPIs. And I don't know if anybody wants to jump on this particular question on population health or outcome KPIs that you want AI to drive for your own organization or teams. I don't know, David, Chrissa, or Başak.
Yeah, I was actually interested to hear either from Navneet or Manash if you think like this new push, Manash, you mentioned digital adoption, like digital literacy. I know Navneet, now we have the CMS access, which is like pushing for that interoperability, which is like that catalyst for AI. Do you see like new business models or, just incentives, downstream for actual individuals in the long term?
Yeah, no, definitely. Especially, I think the implementation of digital platform is going to rapidly explode given the directive from CMS, right? And the fact that, and if I understand the CMS regulations, they're going to actually support in this 10-year project, the Access project, digital platforms can apply to them independently and get approved to move forward with them, right? So from that vantage point, I think it's going to be quite valuable. The thing that I, as a clinician, am always concerned about, right, is there's a patient population that is on the commercial side, and then there's a patient population which is Medicare, and then there's a patient population which is Medicaid, right? And as our population ages, I just get concerned about the thought that these 70-year-old and 75-year-olds are going to be engaging with digital platforms, no matter how savvy they are. The faith in that, I think, is going to be still quite fascinating, right? So I go back to what Başak so eloquently stated initially. It is, what is the business that we're in, right? Are we in the business of selling a product such as a digital platform, or are we in the business of taking care of patients, whether it's for the chronic diseases that they have, or there's an acute condition that they encounter that we need to get them through. So there's this faith in technology. I love technology, right? But the faith in technology, that technology is going to solve the healthcare cost conundrum, I'm a bit cynical. I appreciate technology, but at the end of the day, it's how we, develop that trust in the technology and in the users of that technology is going to be much more critical.
Fantastic. Thanks a lot, Navneet and Manash, for sharing your insights on this. And now we are jumping onto the last question, which is more about ROI scalability and how the future is going to look like. And David, I would request you to share your insights on this. Looking at total cost of care, ROI on AI investments, and interoperability with patient-owned data platforms, how are you measuring success beyond pilot stage? Where do you see the biggest opportunities and biggest risk for payers over the next 12 to 18 months? David, please.
Yeah. So let me kind of talk a little bit about and summarize some of what I heard before to kind of set up the answer to this question. I think what we heard before is that enterprises need a real well thought out KPI hierarchy that rolls up operational KPIs, such as those that I mentioned earlier around data quality and AI readiness, into the most important tactical and strategic KPIs driving the enterprise's performance. So there's this hierarchy of KPIs. And so, the strategic KPIs are the most important, but if you look at from a data and analytics operational perspective, what KPIs could roll up into those enterprise-wide strategic KPIs, it is, I'll rename it the ITACT data quality KPIs I mentioned previously, as well as KPIs that measure the effectiveness of what I talked about earlier, which is the data value chain. That's taking onboarding data, refining it, analyzing it, and creating data products, right? So do you have a good factory for creating insights from data? And how efficient is your factory? And so, I think that's, a very important thing is to have, an efficient factory and an efficient set of data quality steps in that factory. As far as kind of the risk and opportunities for health plans, I see kind of two areas. One is in healthcare interoperability, which we've mentioned, right? And the opportunity there is using the CMS mandated healthcare interoperability standards, which are the FHIR standards I mentioned before, using those not to just solve the use case that CMS said we should solve, to be able to conceptually share information across about a patient, with their own apps or with a provider, right, from a health plan's perspective. But really going beyond that, check the box. I implemented the CMS API for whatever they're having the API for patient data sharing, but actually thinking about how do I use that API strategically to drive more real-time community-based health record, and then doing AI algorithms for risk and other reasons. And those kind of the other risk and opportunity is those AI algorithms. The risk is that they aren't based off of peer-reviewed, scientifically valid algorithms and data, but are something less than that, so that the answers they give back won't be meaningful. And so making sure that that any AI that we have is scientifically based, peer-reviewed for correctness, and answers the question well and thoroughly for the audience that it's trying to answer whatever question it's seeking. So whether that be a patient, or for a provider, or for a care management team.
Interesting. Thanks a lot, David. And Başak, if I ask the same question to you, how are you measuring success beyond pilot stage once these solutions are implemented?
I think, in my opinion, ROI really doesn't come from the model. It comes from behavior change at scale. I think David mentioned a little bit. I think one of the biggest traps organizations fall into is measuring the ROI too early and too narrowly. So they look at pilot performance, model accuracy, technical success, and assume that it will translate into value. But real ROI really comes from later, when the solution is actually embedded into the workflows, and it also starts changing behavior consistently across the organization. So what I see working best is that two-level view. First, there are quick wins, right? Where AI reduces friction, cost inside existing operations. There are areas like this, first call resolution areas, or handle time, or care manager throughputs, or case prep times. These are easier to explain, easier to adopt, and they show value quickly. Then there are the more strategic bets where AI starts to reshape how decisions, care, and cost are structured across the enterprise. And those take longer, and they depend on really stronger data foundations, governance, and also workflow redesign. So the mistake is really expecting strategic bets to pay off like quick wins, and that's different. They play different roles. An example, for this is operational quick wins, such as improving those first call resolution, reduces average handle time. It increases some of the onboarding completion, and they can show measurable value really fast because they sit close to those controllable cost and existing workflows. They build credibility fast, and they can help fund the larger journey. But really, they're not enough on their own. So without deeper data workflow redesign, those wins will plateau after a time. So that is where I think strategic bets come in. So I think one of the larger industry signals lately is moving away from this pilot success as the main proof point. More leaders in this industry are asking what is actually in production, what is being used consistently, and what is creating system value. And I think the shift is from measuring that data to measuring decisions, and from pilot successes to really embedded operational values. I answered it in a long way, but I think that is the thinking behind.
This is fantastic, Başak. And Chrissa, from your perspective, where do you see biggest opportunities and risk for Payors in the next 12 to 18 months? What do you think?
Yeah. Well, as a tech company, right, success beyond the pilot stage for us really comes down to demonstrating sustained impact on total cost of care and measurable behavior change at scale, which Başak mentioned too. But I want to go back to something Navneet mentioned or alluded to, is that, we don't want technology to be the end all be all or see it as the solution, especially with, a large aging population. And I think what we're doing at Patientory is essentially created more empowered and educated, patients when they are able to control and own their data and really be able to, bring this multi-source disparate data into one view and into one locale. We can start to see better empowered individuals that are more motivated, right, to make better decisions around their health. So what matters most is moving from, point in time results to consistent performance across population, which requires the integration of the clinical, the claims, and the real world behavioral data into that continuous, feedback loop. And this is where I think, AI is going to be, the most beneficial, right, in terms of a personalization, but also an education component. So looking ahead 12 to 18 months, I think the biggest opportunity for payers is leveraging AI and longitudinal health data to shift from more reactive care to continuous, population health management, particularly in chronic diseases, where, most of those cases are concentrated. But the biggest risk, of course, is investing in AI is, without fixing the underlying data and an engagement layer, we're just going to end up with what we have today, right? That fragmented insights, low adoption, which we see from a lot of point of service apps and solutions that are out there, and that limited ROI. So I think, payers that will win in the AI adoption race will align to data infrastructure, incentives, and more care models that drive real behavior change, and not just, deploy new technology.
Fantastic. Thanks a lot,
Can
Chrissa.
I add
Please, Başak.
to Chrissa's? I think going back to, if we think we're in the business of selling products, we'll optimize with the help of AI transactions. And if we understand we're in the business of serving people, we'll design systems that actually support decisions, trust, and outcomes. So I feel that the organizations that will get most of AI are the ones that are clear about this. So if we're designing for people, AI will amplify that. But if you're designing for transactions, it just accelerates the same limitations, in my opinion.
Thank you. Thanks again. Thanks a lot, all the panelists. I think this has been a very insightful conversation, and thanks to our diverse panelists coming from different backgrounds, different experiences, and sharing all these insights today. And I think we heard it loud and clear that KPIs that matter most combine data readiness, operational efficiency, clinical outcomes, and measurable ROI, all while keeping member privacy, interoperability, and the care for the patients front and center. Obviously, AI is not a magic. It is disciplined measurement that turns data into dollars and better health. Again, really appreciate the insightful conversation that we have had today. Thanks to all the panelists. And I'm sure that this is just the beginning of this relationship, this partnership. I'm sure there'll be many more such conversations that we'll be, conducting together and supporting each other in making the overall healthcare ecosystem more efficient and more patient oriented. So thanks a lot for your time today. Really appreciate it. Thanks a lot for the fantastic insights. And let's work together. Let's collaborate to support each other. Thank you very much. Thank you.
Wonderful.
Bye-bye.
Thank you.
Take care. Bye. Thank you.